I would like to invite the chairpersons, Dr. Rakesh Sahai, who is the immediate past president of RSSDI and ESI, and current president of Southeast Asia Federation of Endocrine Society, and Dr. Chandraya V, who is the senior consultant physician and diabetologist at Sagar Hospitals, Nammo, Bengaluru. Over to you, sir.
So good afternoon. It's our pleasure to introduce the next speaker, who is a well-known figure nationally and internationally. Dr. Shashank Joshi is the past chair of IDF. He's the current chair of the IDF-CR, and he's a Padma Shri awardee. He's been president of several associations. He's currently the president of Indian Academy of Diabetes. He's the past president of Endocrine Society of India, RSSDI, the API, and also the Indian Thyroid Society. He's been past dean of the Indian College of Physicians and also the chapter chair of ACE India. So welcome to Professor Shashank Joshi to speak on Diabetes Remission 2025. Is it a myth or reality? He's going to speak on.
Thank you, Dr. Rakesh Sai and the chairpersons for the kind words. I have to thank Dr. Srinivas Murthy for his invitation here, and he wanted me to speak on diabetes remission. I don't have any duality or conflict of interest for this talk, though these are my disclosures. So what I will do in the next 15 minutes is, we all know that diabetes remission is possible in the type 2 space. In the type 1 space, there was one Chinese report which came in last year. So there is a lot of hope and hype, but no reality. It's all linked to a twin cycle which Professor Roy Taylor alluded to, fatty liver, fatty pancreas, and that was a twin way to reverse diabetes. So there's a lot of AI in this space. There are a lot of new drugs which are in this space. So there's lifestyle, there is drugs, there is also endoscopic bariatrics or endobariatrics, which is a new specialty which is emerging in a big way because they are doing everything which a surgeon can do. And then of course there is bariatric surgery. So you can reverse chronic disease. And there is some RCT and new data which I want to share. So this was the term which was coined called remission, not reversal, which means this is the best term to normalize glucose in type 2 diabetes, where the A1C is below 6.5 for 3 months without diabetes drugs. While in reversal, somebody can be on metformin. Second is, of course, keep the plasma glucose below, multiply the millimole by 18, and you can also use a CGM value. Then, of course, the A1C should be measured before the intervention, whether it is a medication, drug, surgery, endoscopy, and after 3 months after ending it. And obviously, we need to keep checking it every year or annually. And this is how the definition was collated initially by a sky diagram. And then they said there is partial remission and there is complete remission. And in the partial remission space, the A1C is between 5.8 and 6.5. The fasting blood glucose is between 100 to 126. 2 hours post glucose value is between 140 and 200. That's where the partial definition is. And total definition is an A1C below 5.7 and a fasting threshold which comes below 100 as per ADA, 110 as per WHO, and a postprandial threshold which comes below 140. So all that has been defined, and this is how the definition came in. We as Indians are different because we are centrally obese at a lower BMI. Dr. Virmani gave a very nice presentation, and we can see that we need to lose fat. To get remission, we need to lose fat. So we need to really see, as you lose weight progressively, the beta cell function will improve, but between 0 to 5%, the skeletal muscle insulin sensitivity improves, the adipose tissue insulin sensitivity improves, the adipose tissue cellular biology improves, the intra-abdominal adipose tissue volume comes down, the intrahepatic triglyceride content comes down, and the liver sensitivity improves. And thereby it resurrects the beta cell. Progressive beta cell improvement can only be seen when we have fat loss ranging from 0 to 15%. And because we are thin and fat, up to 15% to 25% is what most people do. This was a study which we did, which was a START study. We have too much of carbs and fats, too little of protein, which was alluded in the last talk. And this was a twin cycle hypothesis. We eat too much. There is positive calorie balance, which causes a fatty liver. And that cycle will lead to insulin resistance and blunt the insulin secretion further. It will pour out triglycerides which will go inside the pancreas, and you will get a fatty liver and a fatty pancreas. And all you need to do is where is the root cause of this metabolic inflexibility. Probably the root is in the mitochondria, and we clearly recognize that the mitochondrial fuel selection of glucose and fat makes us inflexible or flexible, and clearly we recognize that it is the capacity of the mitochondria to switch freely between oxidative fuels based on the nutritional context is lost when you are obese or type 2 diabetic. And that's the reason for disease progression. And clearly we recognize that when we have hyperglycemia and overloaded free fatty acids, you get a lot of epigenomic changes, mitochondrial biogenesis is blunted, and you get fundamentally dyslipidemia, dysglycemia, and hypertension. And we all know this very well, that either pharmacologically or through exercise or through caloric restriction, you can improve mitochondrial function, mitochondrial biogenesis, decrease the reactive oxidative stress, improve insulin sensitivity to get back normal metabolism and normal cardiovascular dysfunction. So just by doing simply cutting carbs and adding protein, and exactly what the previous discussion which Dr. Virwani was talking was setting a context for my talk. This was the ICMR INDAP cohort. Dr. Mohan was the lead author on this study. We were all authors on this study. You could see that if you just cut your carb and add protein, this was data driven through an AI model from the ICMR INDAP cohort, you could actually get remission in the Indian population. So if you just drop your carbs by 5 to 10% in your diet and add some protein and up it to maybe 1.5 grams per day, you can do that. We actually did this simple study which we put out at ACE, where we took 42 type 2 diabetic subjects, used the diabetic specific nutritional formula, either partially or totally replaced it. We did AGP on them, looked at them for 1 year. We didn't offer them any drug. We got 4.6 kilogram weight loss, A1C reduced by 1.2%, and the overall area under the curve for AGP came down. And here is an illustration. You can see her very clearly. Some patient who came in with an A1C of 7.6 came to 6.1 just by replacing a meal replacement formula. So historically, we have seen there have been very low calorie diets and low calorie diets. And the first options to reverse diseases came through VLCDs. But unfortunately, VLCDs had low quality protein and insufficient micronutrients, which led to severe sudden deaths between 1976 and 1978. And therefore, the Codex Authority from Rome Declaration introduced safety standards. And they clearly said in 1995 that if you are having a very low calorie eating plan, it's between 450 and 800 calories, or low calorie diets between 800 to 1200 calories, you need 50 grams of protein, it should be replete with micronutrients, and it should have 7 grams of fat per day. You need all that. The first hint of remission or reversal came from Poris et al. From our surgeons. And they were able to normalize in obese type 2 diabetic subjects in 90% disease-free state after 10 years with bariatric surgery. And Professor Roy Taylor is the guru of caloric restriction of around 800 calories, similar to the effect of bariatric surgery. And he documented that just by eating 800 calorie diet, you can restore the first phase of insulin secretion, which is lost during the type 2 diabetes. And his direct trial, which was published almost 8 years back in GPs of United Kingdom, showed very clearly that if you have diabetes not more than 6 years, BMI between 27 and 45, not receiving insulin between 20 and 65, you could clearly see that it was improving. Half the patients were going into remission, and there is 5-year data to show that it does persist in a realistic. So what was the philosophy of Professor Roy Taylor for remission? It was a very simple, direct principle: meal replacement with a low calorie diet, negative calorie balance, depletion of the liver and pancreas fat, and reversal of diabetes. So this was the basis for remission programs. And with that, what they achieved was gastric emptying, glucose, insulin, GLP, CCK, and GIP, everything was improved. Who responded better in remission? People with shorter duration responded better, younger population responded better. So yes, natural history of type 2 diabetes can be reversed, and that is possible. And then came the advent, because when direct trial was done, we didn't have on the body implantable devices like CGMs or flash glucose monitors or the monitors, and I'm just coming from ATTD from Amsterdam, and very clearly now we have a monitor which we can put inside your body for 360 days. It's called Eversense 360, and you can clearly see that this has been a game changer now. So you can clearly see that the whole CGM, which is like a metabolic dashboard, has changed the way we can reverse disease. And you can see the first generation from 70s to the latest generation now, where we can do 360 degrees 24/7 glucose estimation, made a change. And clearly, therefore, most of the models of remission are based through machine learning and artificial intelligence, need a CGM sensor or measurements from glucose, various other health metrics, and actually process it through an artificial network. I learnt a lot of my AI through my gurus in AI, Jahangir, who actually is the world leader. He put internet inside the mobile phones, and he used to own a company called Jasper Technology, which he sold to Cisco. And then he started this Twin Health, and he reversed healthy disease plans. And what was this all about? It picked up health signals from CGM, from Fitbit, from physical activity, happiness signals from coaches, and treatment signals from doctors. And he processed them through an AI model, like machine learning. Like if you are Googling a search, right now my good friend Suresh was saying we have to go to Chicago. I told him go on an incognito app and Google out what is the best option through an AI. And we can use the same thing to reverse chronic diseases, to get precision nutritional advice, sleep advice, precision medication advice, and it has to be handled by a coach and supervised by a doctor to reverse this. And what it gives us is insight about food. Now, all of us may have had a dosa in the morning. Rakesh and me had dosas in the morning. We may have different responses. Somebody may have a green response, somebody may have a red response, somebody may have a fair response. And it's important to understand that over a period of time, if you have more sambar, less dosa, you put some protein in the dosa, you might be able to make it green. So it's important to recognize that fact very clearly. We all live to eat food. So you can actually predict on taste what food, what meal, what combo, how often. For example, somebody is having 3 idlis and half vati sambar, and the sugar is 300. You just make it 2.5 or 1.5 vati sambar and maybe a half idli, and your glucose will come down. It's very, very accurate. It's more accurate than with a very high precision. This is what it is all about. If you want to reverse glucose, you need to do CGM, blood pressure, ketone monitoring, body weight, body fat percentage, Fitbit, process the blood work, put it through an app, recognize all the factors including sleep. Sleep is a crucial factor, micronutrients, energy, symptoms and medications. And once we have processed them, the continuous machine learning learns the precise macronutrient, micronutrient and gut microbiome, the sleep and physical activity, and with the help of a physician and a coach will try to tell the member how to make the reversal. And over a period of time, the machines learn somebody's habits, the habits on weekdays, habits on weekends, habits when you travel, and then ultimately these logs are all mapped in. And fundamentally, all this data allows us to give us precision guidance. So this AI term is an old term, in this 50s to 80s term, which was nothing but a simple rule-based expert system. The ML is a newer term, which is basically a subset of AI, which is automated. So it is based on regression models and gradient boosted trees. But the main one which we see now in a deep seek or the new algorithms are deep learning. Deep learning is nothing but a deep neural network and a generative AI like a chat GPT or a sugar GPT or so on and so forth. And what it does, like for example, Twin is an example, it picks up the biological constructs, the behavioral constructs of nutrition, activity, sleep, breathing, meds and the mind and the social demographics, and all of that is trained. For example, everybody may not walk 10,000 steps. It takes 3 billion steps data points over 10,000 people over 3 years. It studies 3 million meals logged while wearing a CGM. It has 16 terabytes of primary data set. And it learns that you cannot give generic advices, eat healthy, exercise more, sleep more. I still will say that in my last slide. But still, it is individualized. Because, for example, eat specific foods. They may be green for my friend Dr. Vasant Kumar, who's in the first row, very active doing social diabetology as a part of his practice and volunteer work, which I compliment. And it may be different for Vijay Vishwanathan, who works a lot in the foot patients, because they may not be able to do physical activity all the time in the client CCs. So it could be different from the people you see in, say, Hyderabad or for Chennai. It's not a generic advice to give 10,000 steps. Some people may need 4,000, some people may need 700. Some people may sleep for 8 hours. My good friend Hemant, can sleep for 5 hours and can be as active and crack jokes, which I can't, okay? While, I may still need my 8 hours of sleep. And my good friend Dr. Narsingan will say, if you don't sleep well, your blood pressure won't get controlled. So it's important to recognize that you need to do this precision medicine. And we have devices to do it. We have CGM to tell us clearly glucose prediction. So glucose prediction is a no-brainer now. We can predict glucose by actually studying the CGM sensor and develop a prediction model on it. And AI can do it for you. Okay, that's possible. And it's very highly accurate. You can predict your CGM after studying it for 45 days. And that's what we have seen. We have published data on it. This was our initial data where we showed partial remission. We put them through this program. We were able to show that in 75% of the cases, we were able to achieve remission. And this was our RCT. Now 3 years are over, and all the 4 centers were in Bengaluru. And you could show that A1C came down by 3.3%, the fasting came down by 76%, and the time in range was achieved. And we presented this data 2 years back at ADA. We in fact had a press conference for the same. We also showed that through the same RCT, you could reverse the MFLD. And that was also what was published. You could see that that data is published now. We could also see that this is not just applicable in the data which is in the RCT condition, but even in real world it is possible. And even in the real world we can do that. It can occur in the obese subjects. It can occur with a lot of things. Now, this is something which may be very useful. We published this paper in JACC in hypertension, the same cohort where we did remission of type 2 diabetes. We published this data in the JACC, Journal of American College of Cardiology, and they wrote an editorial on it, that you could even remit hypertension. And you could see that using people with type 2 diabetes and hypertension, a smartphone app, a digital application, using precision treatment, a virtual platform for blood pressure control, we could actually take them off their blood pressure medications. And in fact, in the JACC, they wrote an editorial on that, and people who work in hypertension may be interested. We showed, in fact, I presented this paper at ADA last year, that you can even remit diabetic retinopathy if it is early. We showed microalbuminuria can be regressed. We even showed a beautiful case report in ACE, clinical case reports of PCOS. We could clearly show depression is improved and obesity markers are improved. And therefore, the precision medicine is all about digital twining. And we can clearly see that you can pick up sensors, pick up blood reports, study the members, use machine learning, artificial intelligence, nutritional database and medication database, and curate a plan with the help of doctor and coach. We are seeing this also with medications, because even if you get 5% weight loss, glucose and blood pressure is controlled. 5 to 10% diabetes, MFLD, PCOS is controlled. 15% you get much more, but more than 15% you get remission. So remission needs 15%. And we have just seen the launch of these big ticket agents, single receptor agents, dual receptor agents, triple receptor agents, and they may put bariatric surgeons out of business. So that is also possible. For example, the triple agent not available in the world now, but will get available soon. The triple G, the GIP, the GLP-1 and the glucagon, retatrutide has shown weight loss of 24.2%. And it is compelling weight loss which we see. So both the dual and triple agents have compelling weight loss. So when we are looking at an overall multidimensional model, we need to ensure that mental health, glucose and behavior can all be modulated. Having said that, we must sleep on time, sleep well. We must do a digital detox. We need to eat less, eat on time, eat in the morning, eat slowly, eat right, walk more, sleep well, and smile, of course. So remission is possible. We are living in an era in type 2 diabetes, where in a multifactorial management model, we can clearly achieve remission, at least in the first decade, decade and a half, with various methods, whether it could be, I showed you an AI-enabled twin model. I showed you a direct model of Professor Roy Taylor where you eat less. You can use the newer drugs, which can cause compelling weight loss more than 15%. Some of them may get available. Access and affordability is a challenge there. And of course, you can do endobariatric surgery also, or bariatric surgery also. And you also can actually do reduction of progression. That is partial remission. With individualized approach of behavior, pharmacotherapy, AI and tools, you can actually achieve it. Thank you so much for a patient hearing.
As usual, Dr. Shashank has highlighted the various newer modalities to use for the remission, especially artificial intelligence and machine learning, to adopt in our practice. Let us hope with that we remit many patients' diabetes. And my question is whether we can maintain this remission for how long with continued same measures, or will they reverse even in spite of the same measures if they follow, whether they relapse with that?
So the biggest problem is persistence. That's where AI is a nudge. See, we can get, in the direct trial, the biggest problem is that the remission rates after 5 years was only 2%. Because you can't be eating 800 calories all your life. But you can, once you normalize your metabolism, then you can persist within for 5 years if you are able to nudge it and make small changes. So initially, probably for the first 30 days to 1 year, you need big changes. But once you reset your metabolism, probably you still need those nudges. You can't be reckless. I think that's why the term remission has been borrowed from oncologists, because reversal gives you a false sense of security. The minute you say that you have reversed your disease, then patients go back to their original lifestyle, which made them go for a chronic disease like type 2 diabetes. The minute you tell them that you are remission, and you are in remission as long as you do these A, B, C, D, E, Fs, then you are good. So I think we still need some degree of discipline. It may not be as stringent as you get into the remission program, and that is where probably AI comes to our aid. That is why where devices like a creation of a CGM, which is attached to you, continuously studying and modulating it, you get that little nudge. A coach supervision, maybe a twin program, or any of this can help you and aid you to maintain it. So the maintenance is the key. And currently we have almost 70-80% maintenance, provided you are able to give them those nudges. Everything comes at a cost. If you tell them free advice, they will relapse faster. If you get them prepaid advice, they will, remit longer and relapse lesser.
So what's the longest duration of remission shown with the twin program?
The surgeons have shown remission up to 10 years.
Yeah.
Twin has shown remission up to 4.5 years.
Any questions from the audience?
Thank you.
So if there are no questions, I think we'll conclude the session. We had a very interesting session from Dr. Shashank Joshi. I would request the...
Thank you so much, sir. Thank you to the speaker and the chairpersons.